Thank you, madam, for your kind introduction. Good morning, everybody. First of all, let me thank the organizing team of MARPCON for inviting me to share my experience about laryngomalacia. But believe me, whatever experience I have about laryngomalacia is all because of you, all because of pediatricians. So the pediatricians who encouraged me to enter into this field of neonatal work, and without their support this wouldn't have been possible. We are doing laryngomalacia work last 5 to 6 years, and the number of cases we are doing is increasing day by day. I feel all of you have few questions in mind, and if I am able to answer these questions which are coming in your mind, like how to diagnose, what is common differential diagnosis, whether flexible scopy I can do, and role of medical and surgical treatment, and prognosis of laryngomalacia. If I am able to answer these in my presentation, then it is the job is done. What is the outline of my presentation is initially in definition, epidemiology, introduction and clinical features, and later part with medical and surgical management. As such, what is laryngomalacia? Laryngomalacia is nothing but a flaccid supraglottic structures causing upper airway obstruction. It is secondary to immaturity of larynx. It is most common cause of stridor in children, infants. So all stridor is not laryngomalacia. This point I want to highlight because there are almost 20 to 25% of the times the cause is different. Etiopathogenesis is exactly not known. It may be a cartilage immaturity or anatomical abnormality or something like a neuromuscular immaturity. More than 70% of the congenital stridor cases in all literature is due to laryngomalacia. Boys are more affected. It is benign, self-limiting, but it may be severe. Depending on the anatomical abnormality, the laryngomalacia is described in different types, like type 1, type 2, type 3, and what all is important is epiglottis, aryepiglottic fold, and redundant mucosa of the arytenoid. The posterior falling of the epiglottis in the glottis is the severest form of laryngomalacia. What clinical presentation, every now and then you are in practice and you are facing all these children, they are having inspiratory stridor which increases with agitation, crying and feeding, more so in the supine position. The feeding symptoms are already there, like choking, coughing, prolonged feeding time, and dysphagia and weight loss. Failure to thrive is one of the symptoms. The conditions which are with laryngomalacia that can worsen the prognosis is like prematurity, neuromuscular disorders, and synchronous airway lesions. Believe me, there are some cases where the two pathologies are there, like subglottic stenosis or valvular cyst along with the laryngomalacia. Sometimes tracheomalacia and bronchomalacia may be coexisting, and these cases are having worst prognosis. There are more than 50% cases you have feeding problems, and obstructive sleep apnea almost in 60 to 80% cases. Now clinical features, if we divide mild, moderate and severe, this is more important when we think about managing the case. If the case is with the mild or mild to moderate, then we can definitely observe the child, and moderate to severe child needs a surgical intervention at an early stage. What is the waiting period is maybe about 6 months, where you follow the child for infections, how he grows, whether the weight gain is proper. There are certain syndromes which are clinically there associated, may cause worst prognosis. What is the differential diagnosis of stridor in a neonate? The conditions are many, and you can enumerate maybe more than 20 different etiologies, but the commonest being laryngomalacia, unilateral or bilateral vocal cord palsy, and subglottic stenosis. Rest of the things are cleft, cyst, webs, and malicias, atresia, hemangioma are rare. Valvular cyst may be one of the cause for stridor. So when we look or diagnose a case of laryngomalacia, we need to rule out other cases, maybe in 15 to 20% of the children. This instrument I want to highlight here is a flexible bronchoscope. It's a very simple instrument, maybe of 3.2 to 2.8 millimeter with the suction channel inbuilt, and anybody can learn this procedure easily. Here I announce that I am able to train whosoever is interested, especially those who are running NICU and PICUs, because this is of great help for diagnosing the cases and treating in some cases in NICU for lung conditions. Rather than having laryngoscope, you can go for a bronchoscope, which is easy to learn. It is done with the awake position condition and in operative room with just monitoring of oxygen saturation. It is passed transnasally or transorally and with the suction channel inbuilt. The advantage of this is it can be connected to camera and can record, and you can later on easy for follow-up also. So this is a child in an awake condition. No need to give sedation or anesthesia. You can just pre-oxygenate the child, may give xylocaine as a nebulization if you need, and then pass the scope transnasally, because you are seeing the larynx in a more physiological condition. What happens with the direct laryngoscopy? You are fixing the larynx, so most of the things are missed. If you are looking the larynx from above behind the palate, and then you are looking the complete anatomy. These are few of the clips where you have long epiglottis, short AE folds, and redundant mucosa of the supraglottis. So tubular epiglottis or omega shaped epiglottis is very characteristic, and short AE folds, aryepiglottic folds, and redundant mucosa. In this clip you can observe there is epiglottis which is falling in the glottis and causing stridor with inspiration. If not treated, it can cause so many problems like elevated risk of GERD, pulmonary hypertension, cor pulmonale, and oxygen level is all less. How to manage this child? If the child is falling in the category of mild or moderate, then you can reassure the parents. The parents are worried about the stridor, the sleepless nights for the parents. They are just by the side of the child. So reassure them that this is self-limiting once you diagnose it completely. Then position adjustments you can do. Feeding modifications one can definitely try for the child, because you are observing the child for growth and weight gain. Reflux precautions you always give, because GERD is usually associated with laryngomalacia, and frequent evaluation by the pediatrician is a must for how the child grows, how the feeding is, and breathing pattern. What are the indications then? Where the role of surgeries comes, or where the role of otolaryngologist comes, and these are the absolute indications when the child is not gaining weight and stridor is increasing, and there is a lot of compromise and pectus excavium is happening. The relative contraindications is repeated aspiration, repeated admissions to the NICU and PICU, then weight loss with feeding difficulty. So all these are the indications for surgery. When not to operate, or when we should operate, but with all caution if there are multiple level problems and there is severe neurodevelopmental comorbidities. Active infection is again a contraindications. Anesthesia, one more pillar for management of laryngomalacia. So I talked about pediatrician, then otolaryngologist, and third pillar for management is the anesthesiologist. You need to have an anesthesiologist who is trained in dealing neonates, then only you can perform the work. And usually if it is tubeless anesthesia without putting the tube in the glottis, the surgeon is more comfortable and can perform the procedure completely. So it is just an inhalational and TIVA. Post procedure we should have oral tracheal tube maintained on spontaneous ventilation, extubated in NICU, again a pediatrician setup after 24 hours. Types of supraglottoplasty or surgery, the number of gadgets you can have. Luckily we are having all these gadgets at my setup also, like radiofrequency, microdebrider, laser and cobblator. What is done in the surgery, I'll be just in brief. The epiglottis is either fixed to the base tongue with the sutures, or there is a raw area between epiglottis and base tongue can be created. And another part of the surgery is trimming the supraglottic tissues by cutting the epiglottic fold and removing the redundant mucosa over the arytenoid. The CO2 laser has advantages and some disadvantages also. The advantage is penetration is very less, so deeper thermal damage is very less. But disadvantage is difficult because it is delivered through the beam and it cannot reach the deep and curved areas. So diode laser is more comfortable for the surgeon and less risk. It is handheld and contact laser, can reach to any area you want. It is small, inexpensive and simple. This is how the diode laser going through the fiber through the suction cannula. The surgeon is with endoscope and camera. Assistant is with direct laryngoscope. The camera is connected to the monitor, and on the monitor everybody is seeing for the surgery. These are few of the cases. The preoperative and operative video where the contact laser or a diode laser is cutting epiglottic fold and the surgery is performed on either side so that you open the glottis and the supraglottis will never prolapse into the glottis and will not cause stridor. At the end of the procedure, you can do just evaporate this redundant or excess mucosa in the area of arytenoid. These are the post-operative videos of 1 week and 3 weeks of the same case where the glottis is all open. Another case of diode laser, just the similar, the glottis is all narrow and elongated, the supraglottis is all deep, and then you are cutting the epiglottic fold on either side and opening the glottis. So on table you get the result because you are opening the, and these are the post-operative videos. I'll not go in another few videos. I have few minutes now. So this is one more severe case where you get a diode laser as an operative and you are opening the glottis there. Radio frequency we have a handheld probe for radio frequency with the lower intensity coagulation and cutting modes, and you can definitely perform the surgery by opening the glottis by cutting on either side epiglottic folds. Microdebrider assisted supraglottoplasty is one more where I don't have a video right now with me here. Cobblator is one more instrument. The advantage of cobblator is it can have a coagulation along with the cutting, sucking and irrigating. Here the tissue edema is less and early recovery. How the child is taken care in post-operative period, it is again pediatrician's role in NICU setting. The orotracheal tube with spontaneous ventilation with T-piece, Extubation is usually advised after 24 hours, rise tube feeding after 48 hours till fifth day, and nebulization done. Then rest of the things are like follow up and everything is done. Rule of tracheostomy is very rarely done when you have three comorbidities. One minute. And severe sleep apnea and persistence of symptoms. What are the complications? The complications are very minimal. You have to do a post-operative good care. The prognosis is overall very good. The results of surgery are very good and very promising. To conclude my talk, laryngomalacia is most common cause. Flexible scope is best for diagnosis. Associated lesions should be ruled out. Anesthesia by spontaneous thing. Laser radiofrequency coablator are the armamentarium. Teamwork with neonatologist is a must, and believe me, it is a teamwork. Not a single person can do all this surgical work and can get the results. So pediatrician or neonatologist, NICU setup, anesthetist, parents, always involve the parents right from the beginning, and always have a counseling sessions with the parents, because this is something which you need to do over a time. Very rarely you need to revise these cases. And I feel at this stage that everybody should learn flexible bronchoscopy. Those who want to learn, I'm there to help you out. But have scopes in your setup, and it is one of the very good tool to handle, and you can diagnose so many cases. After you diagnose, you can definitely consult a otolaryngologist for surgery. Thank you very much.
Thank you so much, sir. It was a spectacular session by you, and it was a great pleasure listening to you. I request Dr. Kavita Mahindarkar ma'am to please conclude the session.
Thank you very much, Dr. Sham Somani sir. It was a very informative lecture by you. 22 years back when I started my practice, definitely the treatment of laryngomalacia was totally different. And surely sir, it's a teamwork of good ENT surgeon, pediatrician, parents, and of course anesthetist. Thank you sir, thank you very much.
Thank you ma'am. I request our chairperson to kindly felicitate our speaker. I also request Dr. Dharmaraj Dugda sir and Dr. Vishal Mahindarkar sir to kindly come up on the stage to felicitate our chairpersons.